thanks the invitation to the organizing committee of the events, especially to Dr. Diogo, and say that it's an honor to participate in this section. My lecture is about ERCP, post-bariatric surgery, mainly in Al-Ainy gastric bypass. My agenda will be
Mohammed, you remove the audio.
Surgery and intestinal.
That's right.
Excuse me, Diogo?
No, now it was working, but once we talk, I'll just put play now, and that's okay.
Okay, fine.
Provides a technically difficult and challenging.
No, when you click on the top, you make mute again. So just click again. No, click again on the screen.
Correspond to approximately
Yeah, now it's perfect.
80% bariatric procedures performed in the US.
Yes, perfect.
36% of
So just leave it. Just leave it.
develop gallstones and 13% develop gallbladder.
You need to click again on the screen because you put a mute again. So just one click and leave it. No, I can't hear. We cannot hear the presentation.
In the journal room link.
Hello, Diogo? Hello?
Just click on play.
Yeah.
Intubation.
Yeah, just leave it now. Now it's working. Just leave it. Don't click anything else.
Correct.
Okay.
Did you know biliopancreatic loop for to rise to the papilla? It's hard and demands more procedure time. By laparoscopic, the surgery makes a percutaneous access to the excluded stomach with the placement of a 15 millimeter trocar. And the second time, using duodenoscope, passes through the trocar to enter the excluded stomach and reach the papilla and perform the ERCP in a traditional way. And by US, using the lens stent, you perform the communication between the pouch gastric and the excluded stomach, and in the second time passes through the lens stent and they enter the excluded stomach and they reach the papilla and performs the ERCP in the traditional way. In addition to difficulties of reaching the papilla during enteroscopy, it is important to show that by enteroscopy technique of access of the papilla, the bioduct catheterization position changes from 11 to 5 hours, with a rotation of 180 degrees, as shown in the photos. Because of that, the low technique and clinical success rates with this technique. This video shows double balloon enteroscopy assisted ERCP, and the finding of the jejunal biliopancreatic limb is essential, and the failure to achieving bioduct with cannulation of the papilla ostium and needle knife fistulotomy was performed, and successful bioduct assess, and the best assist the common bioduct stone extraction. This showed the second endoscopy approach to laparoscopic assisted ERCP. In the photo one, laparoscopic imaging showing the excluded stomach fixed on the abdominal wall with the trocar inside. And the photo 2 shows the position, how endoscopy works. And the photo 3 shows the duodenoscope through the 15 millimeter trocar. And the photo 4 shows the fluoroscopic image. And 42-year-old female that ERCP 10 years ago for choledocholytitis, cholecystectomy 9 years ago, Ru and Y gastric bypass 6 years ago, and the cervical cancer treatment 2 years ago. And now presented with abdominal pain and jaundice, and the total bilirubin 13 indirect predominance, and CT abdomen show dilatation of intra and extrahepatic bile ducts, and the surgeon indicated ERCP through the excluded stomach guided by laparoscopy. This clinical case, after the surgery, fixed the stomach, excluded stomach in the abdominal wall. I introduced the duodenoscope, the excluded stomach, and the ERCP show the stenosis in the middle distal third of the common bile duct, performs the biopsy, guided by forced biopsy, the biliary stenosis here, in the biliary stenosis here, and inserted the plastic biliary stents, and the option for endoscopy ultrasound was performed to identify the stenosis, and here show the stenosis and the lymph node perilesional stenosis. Here show the stenosis and the upstream dilatation and the biliary tree, and then here the stent and the stenosis, and it performs the fine needle aspirations and the stenosis and the lymph node. Histological diagnosis show the stenosis and adenocarcinoma, and the lymph node is no evidences of neoplasia. And after these procedures, the patient sent the oncologic surgery. The future of therapeutic endoscopy has arrived after hot lens and luminal opposed metal stent, initially indicated for the treatments of pancreatic fluid collection and currently used in the other disease. In advanced centers for therapeutic US, where you have expert physician in ERCP and therapeutic US, today we have a paradigm change in performing ERCP in the Ru and Y gastric bypass patients with the performance and the gastric access temporary for endoscopy. 34-year-old female, history of a prior Ru and Y gastric bypass 4 years old, cholecystectomy 3 years ago, and presented with abdominal pain and intermittent jaundice, and ERCP CBD measured 1.2 centimeter, and 2 distal bile duct stones measured 6 and 7 millimeter, and indicated ERCP through the excluded stomach guided by gates. Indicate for the gate for the patients, and gate plus ERCP in 2-step approach. The first step in the gate, in the first day, and then identify the standard dollar signs in the excluded stomach, and the puncture and the contracts and methylene blue injects in the standard stomach, and the distal flange deployment here, and the proximal flange deployment here, and they create the fistula and the pouch and the excluded stomach. This is final appearance. And the second step, 7 days after, lens corrected position, and the guide wire and balloon passes the excluded stomach, and the 15 balloon dilatation, and duodenoscope passing the measured papilla localization. After this, you biliary cannulation, and here in the bioduct contracts, and they show in the bioduct stones. And now it performs the papillotomy and remove the bioduct stones, remove with the distracting balloon. After the ERCP, you lens with a forward body forceps, and left to placements and the double pigtail. And after 14 days in the evaluation, after remove the lens and they completely close the fistula, and the follow-up the patient is asymptomatic. Literature results. This is a retrospective shite review. Was performed in patients with RYGB anatomy from 2009 to 2019 at 2 tertiary centers in the Harvard group, and totally included 130 patients 42 patients underwent the laparoscopic group, and 70 patients in the enteroscopy group, and 18 patients in the gate group. And the success rates for gate and 100%, and 98% in the laparoscopic group, and 59% in enteroscopy group. And the require rescue therapy and 26% for the enteroscopy group, and the diverse events and higher in the laparoscopic group, 31%, and less in the gate group, in 6%. And the rates of hospitalization post-procedures less for gate group, in 44%. And the cost utility is less for gate and enteroscopy group, and the higher for the laparoscopic group. Gate is a safe modality for ERCP with high success rates in RYGB patients, and exhibits the lowest hospitalization time and the rates of diverse events when compared to enteroscopy and laparoscopic group. And gate is similar for enteroscopy from a cost utility approach, and the both are less costly than laparoscopy. The message for ERCP, RU, and EHGC bypass, and ERCP and the enteroscopy has a high success rates in the short loop reconstruction, but in the long loop reconstruction, as RIGB, the success rate is lower. Disadvantage availability of specific devices and accessories. And the ERCP laparoscopic has high rates of technical and clinical success, indicated mainly in cases of associated cholelithiasis. Disadvantage in difficulty in surgery and endoscopy schedule. And the ERCP in the US has high rates of technical, clinical, and clinical success, regardless of the loop length. But the advantage, it's a highly expert endoscopy need. ERCP in altered anatomy is technically challenging and should be performed by the most experienced endoscopists. And they choose the most appropriate approach to the patients, considering the availability of the equipment and accessories, in addition to expertise of each institution. And thank you so much. I am available for discussion.